Good afternoon, ladies and gentlemen. Welcome back to the Li Shui Symposium 2022. I'm Dr. Adeline. Let me introduce my co-chair, Dr. Bong Tang. We are the chairpersons of Symposium 3, and the title for this symposium is Traditional Subspecialties 2. Now, moving along to our sections, may I invite our first speaker, Dr. Gladys Low, to the podium to prepare for the first talk. Dr. Gladys Low is currently head Department of Diagnostic and Interventional Radiology, Hong Kong Sanatorium and Hospital. She is also Honorary Clinical Associate Professor in the Faculty of Medicine, Li Ka-shing Faculty of Medicine, the University of Hong Kong. Congratulate Hong Kong Sanatorium on its 100-year anniversary. I also want to thank the organizing committee for inviting me to speak today. Dr. Lee, Mr. Lee, Dr. Cho, members of HMC, friends and colleagues, thank you very much for coming today. Okay, so basically the title of my talk is Personalized Radiology in the 21st Century. And I'll talk about the history of the Department of Radiology and give some examples of the personalized imaging. The X-ray department started in 1939. First X-ray machine was bought in 1946. And the first full-time radiologist came to Hong Kong Sanatorium in 1954. Dr. Cho Jia-hei is my predecessor, and he was head of Department of Radiation Therapy and Radiology during 1970 to 1995. Forward to today, we now have 17 radiologists and 41 machines. So we have manpower with expertise and state-of-the-art machines with the latest technology. So certainly we can offer personalized imaging to our patients. So 1946, first X-ray machine, 1969, fluoroscopy, 1981, CT scan and ultrasound, 1990 was our first MRI, 1991, first mammography machine, and 1995, first angiography machine. Now let's talk a little bit about CT. In 1981, that was the first CT scan at Hong Kong Sanatorium. And I can tell you that Dr. S.P. Lee would come by the CT department every day to see how the CT scan was doing. Okay, subsequent to that, then we bought a 4-slice CT, 16-slice CT, 64-slice CT, and 320-slice CT. And we were able to offer CT coronary angiogram and CT dual energy scanning. So this was at the opening of our 16-slice CT scanner. You see Dr. S.P. Lee here. And he pulled me aside and he said, Gladys, what are you going to do? Sure enough, subsequently, we had to move to other floors. So I said that we were able to get a head start in doing CT coronary angiograms. And to date, we've done over 50,000 CT coronary angiograms. Obviously, not all patients have normal sinus rhythm. We've been successful in doing diagnostic studies on patients with heart rates of 29 to 225 beats per minute. So personalized imaging is offered for patients with sinus bradycardia, sinus tachycardia, atrial fibrillation, atrial flutter, ventricular ectopics, and coronary artery bypass grafts. So this is one patient here with atrial fibrillation, heart rate on the table was 29 to 180 beats per minute. This was our coronary angiogram on the patient. And another patient here with coronary artery bypass grafts, 2 venous grafts here, and 1 lima graft here. What about dual energy scanning? Well, dual energy can differentiate and classify tissue composition. It turns out that if you can scan a structure with 2 different energies, then you can work out the attenuation curve for that structure throughout the energy spectrum. So you can see that in green is the attenuation curve for the gallbladder. In red is the attenuation curve for the kidney. And in yellow is the attenuation curve for the retroperitoneal fat. And they are all different. All these curves are different. Let's look at an example. This was a 53-year-old male with 5 solid masses in the right kidney and 6 solid masses in the left kidney. The burning question was, are these masses the same? And how many of these have to be biopsied?
Well, dual energy is perfect for working out this problem. You can see that the mass in the upper pole of the left kidney and mass in the lower pole of the left kidney are exactly the same because their attenuation curves are identical. So actually all 6 masses in the left kidney had identical attenuation curves. What about the right kidney? Well, the right kidney is, the cursor is in blue here and the cursor in pink. And you can see that they also match. And they also match with the red cursor attenuation curve. So 11 masses are in both kidneys, but they are all of the same material, and so only 1 biopsy need to be performed. And this was a non-fat containing angiomyolipoma. In July of 2020, Hong Kong Sanatorium launched the Acute Stroke Activation Program. And we provide 24/7 emergency imaging for acute stroke patients beyond the critical 3-hour time window. Let me say that HKSH is the only private hospital to offer such a service. So let's look. This is a patient with an infarct and a CT scan is performed, and there's an ischemic infarct in the left frontal lobe and left temporal lobe. So most people would just stop there. But to provide personalized imaging, we did perfusion scan on the patient. And with the help of a rapid software, a software called Rapid, which the hospital bought for us, we're able to calculate exactly the amount of infarcted brain tissue and the amount of ischemic brain tissue. So if the ischemic brain tissue is more than the infarcted brain tissue, then there's salvageable brain tissue present for this patient. So you can clearly see that there is more green here in this patient than purple. And so the therapy can go on. And so we also did a CT angiogram, and there's complete blockage of the left internal carotid artery. Patient went on to thrombectomy, and you can see the very successful procedure. The left internal carotid has opened up, and the patient did very, very well. What about MRI? A little bit of history on that. We had a 0.5 Tesla unit in 1990, 1.5 Tesla unit, and then a first 3 Tesla unit in Hong Kong. And we were able to offer MR cardiac exams and also MR whole body scan for the patient. So again, Dr. S.B. Lee, members of HMC, was there for the opening of our MRI scanner. So what is the ASAP program actually can also be applied using MRI. MRI actually has the advantage of directly imaging the infarct with MR diffusion. The entire MR imaging protocol actually takes only 30 minutes, and it's, the reconstruction is actually faster than CT. We don't have time to talk about whole body imaging, but let me just say that our article on whole body imaging was the first article in the world about MR whole body imaging. There is customized protocol with maximized diagnostic information in the shortest time for the patient. In October of 2019, we were awarded a certificate for Center of Excellence in Prostate MR by Radboud University. Radboud University in Nijmegen, Netherlands, is actually the leading MR prostate center in Europe. The center pioneered the MR prostate reporting program called PIRETS, just like BIRETS in breast. So 3 radiologists and 2 technicians went to Radboud University to learn how to read MRI and how to do the MRI properly. And we've done close to 5,000 cases of MR prostate. We practice multiparametric MR in prostate. That means we do anatomic imaging, diffusion weighted imaging, and dynamic contrast enhancement. The prostate is divided into many different zones, and the MR actually can show all these different zones, and that's why it's so useful. This is a patient with a mass in the left anterior transition zone. There is positive diffusion here, and there's a washout curve, and you can see that there's actually very rapid blood supply to this region. Now, it was very lucky that this patient went for an MRI before biopsy, because there are only 20% of tumors occur in the transition zone. And if the clinician did a blind biopsy, this area is likely to have been missed. Now, another patient here with a mass in the peripheral zone of the left prostate, positive diffusion and washout curve. So again, highly suspicious for prostate carcinoma. So we don't stop there. To personalize this, we draw the outline of the prostate in green, and we draw the tumor in red, and we create a 3D image of the MR and fuse it with the ultrasound image so that the ultrasound biopsy can be very accurately performed. This was an adenocarcinoma, Gleason 4+5. Now, what about interventional radiology? We do quite a number of interventional radiology, vascular interventions and non-vascular interventions. I don't have time to go through all this, but let me tell you that each one of these examinations are personalized. So I'll only show you one example of what we do. This is a patient who has proven breast CA and had undergone neoadjuvant therapy. And the clinician wanted us to localize all the 3 markers in the breast, and these are seen in with the yellow arrows, and 2 groups of microcalcifications. And so there were 5 wires placed into the breast of this patient instead of 1. And the successful result is that the patient had no residual tumor post-neoadjuvant therapy. So looking forward, I think we will embrace artificial intelligence as a radiologist to use it to help us read some of the scans. And also for the machines, they will also be using artificial intelligence. CT scanning, there's something called photon counting CT now. And that is very efficient detection of the X-ray. So we will look forward to faster scanning, higher resolution, lower dose, and more accurate functional imaging. And for the MR, there will be multinuclear imaging. Right now, we are imaging hydrogen ion. And so there will be many exciting things to come. Thank you very much for your attention.
Thank you, Dr. Low, for the very enlightening lecture that brings us along the journey from our history to the new development, where we always strive to provide patient-centered care and new technology. So may I ask any questions and comments from the floor? If not, thank you again, Dr. Low. And may I invite our second speaker, Dr. Walton Lee. Dr. Lee has established and since then be the head of Department of Ophthalmology in the Hong Kong Sanatorium and Hospital in 1980. In 2005, he was elected chairman of Board of Directors of the hospital, chairman of the Li Shufen Medical Foundation, and was appointed medical superintendent of the hospital. Since then, he was appointed honorary professor and honorary fellow from multiple departments in the Hong Kong University and Chinese University of Hong Kong. Today, Dr. Lee is going to share with us his insights in seeing the better future for us. Thank you, Dr. Lee.
Thank you very much. Let me update you on what's been happening in the field of ophthalmology. Now, our ophthalmology service covers not just general ophthalmology, but also the ophthalmology subspecialty areas. In recent years, there's been a lot of advances and new developments in that changes our treatment and how we look at certain eye diseases. So what I'd like to do is to share some highlights with you across these disease entities of our subspecialty areas. Well, let's look at the update on the most common surgeries that we do in ophthalmology. Refractive surgery, it's really had taken off with the introduction of LASIK surgery in 1996. And what's the status of the LASIK surgery now? Well, we create a corneal flap, the laser, we lift up the flap, treat the underlying stroma to reshape it. The flap is repositioned, and by the next morning, the patient can see very well with minimal discomfort. And over the past years, the advances in LASIK surgery has been the improvement of the laser technology to allow very precision treatment and even customized treatment for each patient. It's a very good result. But that is reaching the end of the technology of that particular approach. So a small incision SMILE, the small incision lenticular extraction, was introduced as an alternate refractive surgery, and using the laser technology to shape a lenticule inside the stroma, and using a side cut to extract that lenticule. So using the laser to form this lenticule and to extract it. So it's a minimal invasive surgery, and it preserves the integrity of the corneal layers. Since 2018, we have the patients, we have the both technology, the LASIK and the SMILE, available for the patient's choice. And so far, half of the patient would choose one and half the other. But like the early beginning of the LASIK, the advances would be in laser technology with the SMILE laser that we had acquired last year, and will be commercially released for wide use later this year. Will be the improvement of the laser in terms of the spot size and the interface use. So that is something that is improving in refractive surgery. What about cataract surgery? The cataract surgery is already quite advanced. You can do the surgery in 15 minutes with just topical anesthesia with a small self-sealing wound. And it's very safe surgery. So the advances a few years have been in the intraocular lens design. So patients do very well with just a monofocal lens, except that you just need reading glasses. But in order to reduce your need of reading glasses, all the previous intraocular lens, the multifocal lens designs have been to try to divert the light into multiple focal points. It works very well, except with all these multifocal lenses, the problem is that the defocus light do cause some interference. So the patient's selection has to be very careful, and except some degree of halos and glare is a limiting factor. So we have the next generation of intraocular lens surface using sophisticated technology to design a lens that can compress the convergence of light to extend the focus. So it's called extended depth of focus lenses, which can give you a better depth of focus without as much optical glare and halo. So this would be an additional option for the cataract patients. The safety of the cataract surgery is such that you can consider having both eyes done at the same seating, and with the use of MAC and audited anesthetics, the patients can choose to be sedated throughout the procedure, and that was to enhance the patient experience. But that unfortunately needs to be done in the hospital setting and not really in the outpatient surgery centers located in commercial buildings. The reason why we have so many, well, this is the extended focus depth of field. Well, the reason why we have good patient load and in refractive surgery is because we have the myopia in children. It seems to be a trend in the number of myopic cases in our patients in Asia. So now we recognize that myopia is not just genetic, but there is substantial environmental factor involved, and particularly even the WHO recommends the outdoor activity time, and studies have also shown additional time reduces myopia. So what do we do to tell the patients, the kids, about their work? So we try to advise them on the posture. And so we also advise them on this 20-20-20 rule. It means that for extended work, for every 20 minutes, you take 20 seconds to look at objects 20 feet away. And that is to give the eye some relaxation. Myopia can be reduced, the rate of myopia with use of low-dose topical atropine. So we have a myopia clinic and a service to help monitor the patients, monitor the dose and duration. And in recent years, even combination therapy, it's being used. Mainly the use of combination of using contact lenses, particularly the autokeratology lenses, the lenses that you wear to sleep and flatten the cornea overnight. So this is a sort of a combination therapy. So the myopia, it's going to be a growing concern for us. So we move on to the corneal and external eye disease area. The major breakthrough is in the corneal transplant. Corneal transplant or penetrating keratoplasty previously involved a full thickness removal of the central corneal button and suture up the donor corneal button with multiple sutures. And that is, of course, quite extensive wound and multiple suture acquisition. So now we progress to recently to a new approach, corneal transplant, using a decimate membrane endothelial transplant. Now, a lot of the times, corneals become opaque, require transplant. It's because of the endothelial cell failure. And so instead of doing the full thickness transplant, you can just use a decimate membrane as a strip. So the donor cornea, you also remove the Descemet membrane, you curl it up, insert it through a corneal incision, and you unfurl it, use the air bubble to pulse it. And so the result would be quite so the problem with the corneal transplant, it's a waiting time. We have only one eye bank, so the waiting period is about 2 or 3 years, but we can obtain donations from overseas eye banks, which will greatly shorten the waiting period. Let's move on to another subspecialty area of glaucoma. Glaucoma is always regarded as the silent sight killer. It's thought to be due to high intraocular pressure. So the patient doesn't really feel anything. And when you get the damage, the glaucoma of the optic nerve, the loss of vision starts from the side to peripheral vision. So by the time you notice vision loss, it's you already have substantial vision damage that is irreversible. So what's new in glaucoma? Well, we understand, however, that glaucoma can exist in normal pressure. And we also know that patients with circulatory problems can be of high risk. So patients with family history, high myopia, and people just need to get tested for the glaucoma. But the previous diagnostic tool in glaucoma is the use of the visual field. But again, because as I say, when you get visual field defect, you already lost some substantial vision. So the technology is to use earlier detection techniques. So the optical coherence tomography, the OCT scan to study the nerve fiber layers and the optic disc cupping and so forth, can give you earlier diagnosis before visual field defects occur. So you can start the treatment early. The treatment of glaucoma, the first time treatment, again, it's just use of topical medications, a combination of different types of medication to control the intraocular pressure. Beyond that is use of laser. But now we have an array of different lasers to treat different approach. And also in terms of glaucoma surgery, instead of doing the usual filtration surgery where we used to make a controlled opening in the sclera to allow the aqueous to filter through, to be absorbed through the corneal bleb. The trend now is to do a more invasive surgery with using stents and internal drainage mechanism and so forth. So the point is, once you diagnose glaucoma, and if the patient is controlled on medication, it's fine. But once it gets a bit more complicated, difficult, this is a time when the subspecialist in glaucoma can't really help because of they will know and understand these new procedures and new technologies a bit better. But the same is said. Let's look at the oculoplastic and orbits. I will I picked the thyroid-associated ophthalmology as an area of development. Well, thyroid ophthalmopathy, it's really quite scary. But these days, it doesn't have to be like that. So in thyroid-associated ophthalmopathy, with a specialist we can help to prevent this disfiguring in cosmesis. So when you develop a thyroid ophthalmopathy, previously the only treatment was use of steroid. But there's a question of when you use the steroid, how strong you use the steroid, and for how long, and so forth. But now we can start the treatment earlier. We have a different protocol for different gradations of the disease. And if necessary, you can go to even more powerful medications. It means that thyroid ophthalmology is going to be an area where the physician treating the thyroid can work and co-manage with our eye specialists in monitoring the eye signs and to be able to start various programs to control the cosmetic change, because otherwise, before one can do the rehabilitative surgery, you have to wait until the quiescent stage of so the co-management of thyroid eye disease is going to be the way to go for the thyroid eye diseases. And finally, in terms of vitreoretinal diseases, I have picked diabetic maculopathy and retinopathy. Diabetic retinopathy from proliferative diabetic retinopathy used to be one of the leading causes of blindness in the adult population a few decades ago, but now it's still going to be a problem with diabetic macular edema. The treatment of diabetic retinopathy, the conventional way, they've been using the laser treatment, the pan-retinal photocoagulation and focal treatment for the diabetic retinopathy and maculopathy. Of course, the problem with laser treatment is it does take time to become more apparent, and the laser, of course, causes tissue damage and some visual loss. So what is new is use of the anti-VEGF treatment in diabetic retinopathy. Started with this cancer treatment for the anti-VEGF. And over the years, we give injections directly into the eye and various anti-VEGF medications are available. So that has become quite what we use in the control of diabetic retinopathy and maculopathy these days. So the current trend in management is still going to be laser and anti-VEGF. What's going on in the diabetic retinopathy? It's going to be the use of perhaps the artificial intelligence, looking at the fundus and other surgical techniques to supplement the anti-VEGF injections. Perhaps a longer acting so that you don't need such frequent repeated injections. The anti-VEGF, of course, is treatment of choice for macular degenerations these days. And finally, in terms of modern vitreous surgery, use of 27G microinstruments. And for macular surgery, instead of most patients don't need to face down for very long, because once you can oppose the macular opening after the surgery, you don't need to have to use a head down position for the gas promenade for very long. So there's been a lot of advances in ophthalmology in the past few years. The subspecialty areas have really complement the general ophthalmologists. So it's going to be the teamwork, and so we'll be getting to assimilate all these new changes that will be seen in the coming years. Thank you.
Thank you, Dr. Lee, for the very comprehensive and enlightening talk. Any question from the floor? May I ask Dr. Lee? Children myopia is very common nowadays, as you have mentioned, and the potential treatment can be topical, atropine, and OK lens. So what will be the best timing or any indication to start treatment in children for their myopia?
Well, you normally like to have a kid 4 or 5 years old when they start off in school to at least get the baseline, and you don't need to treat them right away. So once they get it, you try to tell them to use a posture and outdoor and 20-20-20 thing, and see if they monitor the progression. That's, we send them off to the myopic clinic for monitoring.
Thank you. So any other question or comments? If no, thank you, Dolly, again. And may I pass to Dr. Tan for introducing the other speakers. Thank you.
May I invite the next speaker, Dr. Edmond Ma, to come to the podium to speak to us on shifting paradigms in pathology from cells to protein and DNA. Dr. Ma is my immediate boss. So we work in the same department. He is an excellent colleague, excellent pathologist, and excellent speaker. Dr. Ma.
Thank you very much, Bong, for the compliment, and I wish to thank the organizer for inviting me to speak. So in this talk, I wish to basically highlight the changes in pathology practice over the years with special reference to pathology development in our hospital. So the microscope is virtually synonymous with pathology, but we still do a lot of microscopy and morphological examination. But my point is, nowadays we do not only rely on a morphological diagnosis, but we are complemented by a lot of more advanced diagnostic tools. So zooming in from the cells and tissues into proteins, we can now characterize the cellular phenotype. Okay, what I mean is that we can study the antigen expression on the cell surface, or even inside the cytoplasm or the nucleus, by basically 2 methods. On the left-hand panel is the flow cytometry, where you use fluorescent antibodies to investigate for protein expression on the cell surface. And on the right-hand panel, okay, you can also do the same on the tissue section by the method called immunohistochemistry. Now, even zooming deeper into the cell nucleus, okay, we can study the chromosomes of the cells by the method of cytogenetics. And we can also label the chromosomes, part of the chromosome or even whole chromosomes, or even the whole set of chromosomes by fluorescence in situ hybridization. And then last but not least, we can zoom into the genes, okay, to characterize the mutations, okay, by various sequencing methods. Okay, so on the left-hand panel, this is a point mutation, okay, or so-called a single nucleotide variation. And on the right-hand panel, this is a small deletion involving 52 base pairs of DNA. So therefore, in fact, we are complemented by all these more advanced methods in making our diagnosis more accurate. But then the question is, does it matter? That means, does this technological advancement really translate into clinical benefit to the patients? I wish to tell you the story of Hodgkin lymphoma. Okay, so the disease was first described by the British physician Thomas Hodgkin back in 1832. Okay, and then at the turn of the 20th century, the characteristic and pathognomonic Reed-Sternberg cells was described by Dorothy Reed, and then this was American pathologist and the German pathologist Carl Sternberg. Okay, so this is a morphology. Now, fast forward to 1982, okay? So this in Germany, Dr. Harold Stein, okay, identified a protein marker, okay? So this is phenotype, CD30. This belongs to the tumor necrosis factor family, which is an important diagnostic marker. But then turned out to be also the drug target, okay, of this very effective anti-CD30 monoclonal antibody, brentuximab vedotin. So in 1995, 1997, okay, with single cell dissection and also molecular genetic techniques, okay, we can now categorically determine that the Reed-Sternberg cells were confirmed to be clonal B cells, okay, since the lineage of the cancer cell is lymphoid. Therefore, Hodgkin disease is renamed as Hodgkin lymphoma. Okay, so this now definitely a cancer of the lymphoid cells. And then more recently, the PD-L1, PD-L2 overexpression, okay, on this Reed-Sternberg cell is found to be due to a 9p amplification. And hence this predicts treatment response to PD-1 inhibitors. So therefore, with the story of Hodgkin lymphoma, I hope to be convince you that, in fact, the new paradigms over the past 100 years really translate to improving diagnostic accuracy, formulating better treatment, and also allow a better understanding of disease biology. There are also other aspects of change in pathology. The role of the pathologist to me changes from a supportive nature, support the diagnosis. So previously we hear the doctors say, the laboratory results are not what I expect, and you must be wrong. To be able to provide a diagnosis when the clinical diagnosis is insufficient. For example, what laboratory tests should I order to make a diagnosis? To be predictive of treatment. So a common conversation that I hear is, can I have an urgent molecular test result since the patient is waiting to start treatment? So we're also moving from manual testing to automation, from being a generalist to a specialist in various disciplines of pathology, and also from morphology and immunophenotyping to cytogenetics and molecular genetics, which I've already described. So in fact, I'm happy to say that the hospital really embraces all these new paradigms and be able to actually see that really happening in the hospital. And I wish to thank staff to provide these photographs for me to show. So this is 1980. So at that time, labs still relies a lot of manual tests. So fast forward to 1998, okay, you see the staff number grows, and then we have this standalone analyzers, okay, so manual to automation. And then in 2002, the histopathology division and the clinical laboratory are incorporated into the Department of Pathology to further advance pathology service in the hospital. This is actually a hidden gem that I find in our clinical lab, okay? This actually belongs to can belong to a museum. So this is a WBC pipette, really precious, okay? So that allows us to measure the manual WBC count, but of course, now replaced by these hematology analyzers that generates many parameters in a short period of time. This is a standalone chemistry analyzer back in 1995. Of course, soon to be replaced by integrated chemistry and immunology analyzers, also linked by a track system. And we also moved from first generation Sanger sequencing into next state-of-the-art next generation sequencing. And as I mentioned, the hospital really embraces new technology, and we are able to benefit from this advancements. And I'm going to walk you through the key milestones of pathology department. So the molecular pathology division was established in 2005. And then in 2007, we became the testing center of the Hong Kong Hereditary and High Risk Breast Cancer Program, which is a collaboration between us, Hong Kong U, Department of Surgery, and the Stanford University Medical Center. And concurrent with these, the Cancer Genetic Center was established. So far, we already tested over 4,000 samples, okay? And then not only that, we are able to have research reports on important findings. For example, novel founder and recurrent BRCA1/2 mutations, the clinical aspects in Chinese patients, our experience in multi-gene panel testing, and also try to characterize some of the beyond BRCA subgroups, especially the TP53 and the PALB2. Now, we also pioneered the application of next generation sequencing in clinical diagnostics. So in 2011, okay, we put the NGS into very good use, into actual clinical diagnostic use, okay, not only research. And over the years, we already tested over 2,800 breast cancer panel testing. We performed over 1,300 myeloid gene panel testing and over 250 solid tumor panel testing. We shall catch up with solid tumor testing. In 2012, we are also the first hospital in Hong Kong to introduce mass spectrometry, so-called multi-DOF, for rapid bacterial identification by our co-chairman, Dr. Bong Tang. So in this way, we're able to give a rapid bacterial identification result to guide the antibiotic treatment in severe sepsis. So in 2013, we also set up a stem cell laboratory, the first in the private sector for autologous peripheral stem cell transplant. As already heard from Professor Raymond Liang, who is the medical director of the program, we have already processed 109 autologous peripheral blood stem cell harvests in 83 patients. So some patients have more than one harvest. Also, note that this number is different from what Professor Leung presented, because not all patients have stem cell harvested are fit to proceed to transplantation. So this covers 43 lymphoma patients and 40 myeloma patients. And besides stem cell processing, the stem cell laboratory actually performs roughly 400 flow cytometry per year on leukemia and lymphoma diagnosis, CD34 enumeration, minimal residual testing, and others. And last year, 2021, we also started the Kymriah CAR T cell therapy. As already heard from Dr. Chai in the morning, we are also the first lab in Hong Kong that performs aneuploidy screening by NGS, okay, to support pre-implantation diagnosis. So we're able to help the birth of a baby to an infertile couple. And this is the first time where baby is born after aneuploidy screening by the NGS approach. And then facing COVID, we are also the first private hospital to provide COVID-19 PCR testing. That's early 2020. And of course, now the COVID-19 laboratory service, okay, has now covered the full range of PCR, rapid antigen tests, POCT tests, and also antibody tests, including both quantitative and neutralizing antibody. Led by Dr. Yong, microbiologist, and Dr. Tang and Dr. C, we have also published on important aspects of COVID-19. Okay, we published on serological response to vaccination in healthcare workers in Hong Kong, safety and immunogenicity of booster vaccination, the impact of vaccination on infection rate, and also outcome of healthcare workers during the Omicron wave, genome sequences of SARS-CoV-2 strains in Hong Kong, the use of nanopore sequencing. This is a third generation sequencing for viral characterization, and also evaluation of rapid antigen kits. And then in the near future, what is coming soon, okay? We are setting up a comprehensive genetic and genomic laboratory in the Eastern Medical Center, the Eastern Cancer Center. As heard from Mr. Lee in the morning, this will be a full range genetic genomics laboratory that is equipped with cytogenetics, FISH, PCR, and NGS capability. And then we are also actively completing, it's near completion, a laboratory automation of clinical biochemistry, replete with a pre-analytical module, and then linked by a track system. Finally, all of this would not happen without the support of a team of very dedicated and competent staff. And I also wish to thank the hospital management for the full support they have given to pathology development. And also congratulations again to the centenary of the hospital. Thank you very much for the attention.
Thank you very much, Dr. Ma. Is there any questions from the floor? If not, thank you, Dr. Ma. Thank you very much. Next, may I invite Ms. Manbo to come to the podium to speak to us on Florence Nightingale in 2022. Ms. Mann, please.
Good afternoon, colleagues, gentlemen, and ladies. And my presentation will be on Nightingale in 2022, nursing development yesterday, today, and tomorrow. And historical development of the nursing, I will talk about the local and also the globally. For the global development, it is led from the household to hospital, and then to the outpatient service, and also go back to the community. In the very beginning, before there were hospitals, nursing started at home. Those who were sick were taken care of by their family members in the home. So nurse from Latin means nursing mother. Before 1500s, the Roman Catholic Church provided nursing care through nuns and monks in monasteries. Such religious roots influence modern nursing also. For example, historically, in the UK, a senior nurse had the title of sister. So at one time, someone called me sister, and then one of my friends said, "Are you a nun?" So, and then in 16th century, the Protestant Reformation made a big impact on nursing, because Henry VIII of England had disposed 600 monasteries. So majority of the convents and monasteries were disbanded. Nuns serving as nurses were no longer able to nurse. Nursing was taken up by the inexperienced women of lower socioeconomic status, unsuitable for other work, replaced the nuns. A major setback for nursing and patient care for about 200 years. Not until the era of Florence Nightingale. Florence Nightingale, born in a very well-off family, their parents reject her to take up nurses. But as nursing at that time was not considered as a suitable profession for a well-educated woman, and also because the lack of training and have bad reputation, they are known as a coarse, ignorant, promiscuous, and also drunk. But Florence Nightingale has a different view. She saw nursing will be an extraordinary opportunity for females. And British government, they are the Crimean War, 1953 to 1956. And Florence Nightingale was requested to help a military hospital in the battlefield. She, with the 38 women volunteer nurses whom she trained, care for the wounded and or the sick soldiers as cutlery in 1854. And she is the one who take initiation to collect data and identify the environmental health concerns. And her scientific research stated that 600 out of 1,000 injured soldiers died due to communicable and infectious disease. You can see from the well-known Nightingale Rose chart. The black one, it is those soldiers died because of the wound. The pink part, it is from all other reasons. But the blue-gray one, part, it is died of infectious disease, typhoid, dysentery, and many others. And then she collect all this data, and then she radically changed the poor living conditions, including hand washing practice, mask and protective clothing, implement social distancing and isolation of contagion, improve ventilation and also the blockage of the sewage, supporting a healing environment, cleanliness, light, and also improving nutrition for the sick and the wounded. And then the death rate drastically reduced from 60% to 42%, then to 2%. And then there's a lot of interesting things from Florence Nightingale, but I just mentioned the last one. She did not take any teaching course, but she taught, did not require to write, but she wrote a lot, 200 books. Did not require to do research, but she did, and her works improve patient outcomes. Florence Nightingale, it is not only changes and have the impact of our nursing practice, because you see that all these mask, hand washing, we are still using it, and also depends very heavily on our infections control. And then the impact on the nursing education, because she is the first one to advocate that nurses should have formal education with theoretical and clinical components and a grounding in basic science. Nurses should be taught skill and habit of observation. Established the first nursing school in 1860, the Nightingale Training School. It is the model training school, so that many of the other places like USA, Canada, and also take it and learn how to set up the training school. So what would nursing be like if there were no Florence Nightingale? So we come back to Hong Kong. This picture, it is the first executive committee members of the Hong Kong Nurses and Midwife Association, 1940. It is the first nursing professional association. And then in Hong Kong Sanatorium and Hospital, we have the school set up in 1927. And then right now, we have different specialties. And then our nursing, it is focusing on the quality care, and also it is the tender loving care. And then the school is different. So this is a long list, very comprehensive history of nursing in Hong Kong, prepared by the Hong Kong University. Of course, I will not go through all this, but there's a few milestones we have to be, take a note on it. It is the 1893, the first 2-year nursing program was pioneered. And then afterwards, in the 1927, and then in the 1931, there's the nursing registration and also the Nursing Board of Hong Kong established. So after this setting up of the ordinance and also the nursing board, the nurses are under regulation. And in 1939, the Hong Kong trained the nurses eligible for registration with the General Nursing Council for England and Wales. And then up to 1990, the first full-time 4-year nursing degree program started. And then 1993, the next specialist had been tried on. And then up to 2021, the voluntary scheme on the advanced and specialized nursing practice commenced. Our hospital have over 60 nurses had registered in the APN of the Nursing Council. How has the nursing changes over the years in the Hong Kong Sanatorium and Hospital? So the nursing education, we are the first private hospital and also the only private hospital have free gazetted school. It's the enrolled nurse school, registered nurse school, and also the midwifery school. And now we are concentrating on the enrolled training, conversion and EN convert to RN, and also the full-time 4-year enrolled nurses training program. So they are having the classroom, they have the interactive section, the simulation section, and of course the clinical practicum. And the program, it is under the regulation of the Nursing Council. And the nursing education, because we are now, other than the theory, and also there will be cover a broad scope of areas. And then we continue, because the nursing training continue to evolve with patient needs and to manage increasing complicated patient conditions. In 1990s, the first 4-year full-time nursing degree program started. But unfortunately, by the second half of the 20th century, The hospital-based education module declined in favor of training program at college and university in American, and our local academics also emphasize on tertiary education. Almost all the local hospital-based training program has suspended for bachelor degree around 2004. We also suspended our RN training program for a while, but soon after we start the enroll nurse and then to the RN program again. How's the responsibility of a nurse changes? No longer is nursing solely considered caretaking. Nurses have a broad scope of duties according to International Council of Nurses. Modern nurse is a mix of knowledge, judgment, and also skill. Especially our nurses, because we have to take care of the patients. And then if the patient's condition change, we have to inform, especially the VMO. Nurses provide patient care, serve as patient advocates, clinical partnership with physicians, lead healthcare teams, and conduct research to improve care. So all the coordinator have done a lot. Nurses help hospitals make improvement in safety and quality and humanize the medical care. For specialization, hospitals have put a lot of resources on our continuous nursing training, and then a lot of our nurses will work in specialty area. Because with the medical advancement and serving patient needs, nurses can practice in many areas of specialization, ostomy and wound care, diabetics, renal care, and many others. The most important one, it is the infection control right now. Because the infection control nurses are working in partnership with the doctors, especially the microbiologists and also the infectious disease doctors. And then they work in hand, have done a lot in the antibiotics stewardship and also in the pandemic COVID-19 period, all these two and a half years. They contribute a lot. Due to shortage of physicians and a growing population of aging adults, as created by the needs of primary care nursing, which nurses also provide primary care service independently, as well as collaboration with other health professions in district community center. It is applied to other sectors, nurses. For the contribution in quality and safety, the nurses have always played an essential role in patient care. Nurses spend more time with patients than doctors. They also interact with every member of the patient's healthcare team. These factors, in addition to indispensable clinical work, empower nurses to ensure that healthcare teams are rendering high quality care. And also, they are very concerned about the clinical outcome, patient safety, and all this. Then the local development of nursing, food for thought. The professional development of nursing in Hong Kong is comparable that in the developed countries, for example, UK, USA, Canada, and also Australia. For the area of regulation, training, and education. But lacking behind in other areas is the advanced nursing practice and also the specialization, and also the mandatory continued education. Because right now, we're still not under the mandatory continued education required by the Hong Kong Nursing Board. Challenges and opportunity for local nurses, and then it is for Hong Kong Sanatorium and Hospital nurses too. The aging population, shortage of nurses, rapid advances in medical practice and technology, pandemic, advanced and specialized nursing practice, clinical leadership. Because for the aging population, the increased needs of the community care, and then 1 in 3 will be over 55 by the year 2066. And then the shifting disease burden reduction in child mortality, but rising tide of chronic illnesses. And also the incidence of chronic non-communicable diseases will continue to rise exponentially, so that our nurses have to know more about all these non-communicable disease. They should be educated and trained to be the health educators and also the health promoter. Because increased expenditure on health and long-term care, and also need to change the current institution and social arrangement for the aging population, then the nurses will have to be adopted in some new healthcare system. Like many of the nurses will work in the districts. Nurses will work as a community and nurses, and then they have to go to the home to do the visit and treatment. So even WHO say we have to enhance the role of the community health nursing. The shortage of nurses, especially the experienced nurses, because you see every Friday, and then the jump advertisement, also the recruitment, and then there's over at least 20 pages of recruiting RN and EN, and then in different posts and also in different specialties. And so especially every hospital and every healthcare organization now, it is in lack of the nurses. Advancement in healthcare technology, then all the changing health delivery landscape enhance patient experience, but are nurses adequately prepared? Our training program and also our education. Pandemic and its impact on the nurses. So they are suffering from the psychological or mental issues and also burnout. And also some of the student nurses are not allowed to go out to the clinical practicums. But if we take this chance, we can learn through the pandemic, and then facing the challenge, I think it's a good opportunity. And also we have to how we prepare ourselves for the advanced and specialized nursing practice. So thank you. It's the end of my presentation.
Thank you very much, Sister Man. Thank you. So with this, it's come to the end of our symposium pre-session. And thank you very much, and hope you all enjoy the great presentations.